Hello and welcome to Health Quest. I'm Kim Colangelo. Today we're going to be talking about caregivers of dementia. Dementia is a loss of brain function that occurs with certain diseases and affects memory, thinking, language, judgment, and behavior. Between 4 and 5 million people in the U.S. each year have some degree of dementia, and that number increases over the next few decades as our population continues to age. It affects about 1% of people between the ages of 60 and 64, and 30 to 50% of those aged 85 and older. And it's the leading reason why most people find residence in facilities such as nursing homes. Most commonly, our caregivers for these folks are spouses, children, close friends, and even neighbors. And for the challenges facing these folks, there are very specific needs for caregivers in order to be able to continue to provide that service for the patient. Today's guest is Susan Gordon from the Area Agency on Aging. She is the Family Caregiver Support Specialist here in St. Johnsbury for the caregiver program Reach Out. And we've asked her to join us to help us to understand this challenge and what is being done and what is available for those individuals who are caring for people with dementia. So thank you very much for joining us, Susan.
Oh, you're very welcome. I'm happy to be here.
First of all, your background, as you and I have chatted in the past, what brought you to working with this very specific population, the caregivers of folks with dementia? Mm-hmm. What is the attraction?
Well, back in 1986, my mother was diagnosed with Alzheimer's disease. So at the time I was working in the computer industry down in Massachusetts, but as soon as we got the diagnosis, I started to attend Alzheimer's support groups, began to do a lot of research to get information, and back there in 1986 there wasn't too much information available about the disease. But anyway, she only lasted for about a year. She also had diabetes, and she ended up having a heart attack, which eventually took her life after about a year. Mm-hmm. By that time, I was quite involved. I started in Massachusetts an organization called the Greater Lowell Alzheimer's Association, mm-hmm. and worked with families there. And when we moved to Vermont in 1988, I joined the board of the Vermont Alzheimer's Association, and in 1990, when they had enough funds to put some staff in place, I became the first executive director of the Alzheimer's Association here in Vermont. And I held that position for 13 years. So all of my past history has been really dealing with Alzheimer's, doing education, working with families. After I left there, I actually worked for a few years with something called the Caregiver Initiative at the Community of Vermont Elders, and worked with professional caregivers. So I have experience on both the professional and the family area.
Boy. Now you had shared something with me that I actually found very fascinating. It was an educational opportunity for me. You were sharing that we often hear the term Alzheimer's and we make a connection with folks, but you told me that dementia is basically a precursor.
Dementia is actually like the sniffles. If you have the sniffles, it may be because you have asthma, or you might have the flu, or you might have a cold. There's several different diseases or conditions that cause sniffles. Well, dementia is that kind of an umbrella term, and there are many different things that can cause someone to have dementia. It could be a stroke, it could be actually even a vitamin deficiency, it could be alcoholism. But Alzheimer's disease is the most common reason for people having dementia.
And so with that in mind, we originally started our discussion about the program that you currently work with, the Reach Out program through the Area Agency on Aging. So maybe you could just take a minute or two and explain to us what the Reach Out program is.
Absolutely. It's a grant-driven program funded actually by the Institute of Health, and it's aimed at caregivers of people who have dementia. It's a free program that's offered here throughout the Northeast Kingdom and in 2 other parts of our state. It consists of 6 monthly visits, 1 to 1.5 hours each, with the caregiver in their home, if they prefer that. And we will deal with them and help them figure out how to handle the challenges that come with caring for someone with dementia, but even more importantly, helping the caregiver understand how to take care of themselves. Looking at their well-being, their emotional support, making sure that they're exercising, eating right, because what we know, of course, is that many times people who provide care for someone with dementia often burn out before the person with dementia. So our goal is to keep the caregiver healthy, which means they, in turn, can provide the best care possible to their loved one.
And I can appreciate this topic, as I've shared with viewers in the past. My life is being affected by this disease as well. My stepdad has dementia, and my mother is the primary caregiver, and I can appreciate so clearly what you say when you talk about the caregiver burning out.
Yes.
Especially, I think, when it's well, I shouldn't say especially, but I know particularly when it's a spouse. That relationship so dramatically changes when one of the members has dementia, and the caregiving then becomes full-time in every possible way, because now they're no longer sharing those responsibilities of running a home and making decisions. It now all has to fall on that one person.
Right.
And maybe just as a side, what would you recommend, or what would you say is one of the key supports that could assist a caregiver in that situation to try to help them cope with that change?
I think something that's really critical is oftentimes caregivers of people with dementia become isolated because their friends become uncomfortable around the person with dementia because the person's behavior changes, and they lose their social filters and things may occur. So friends and neighbors many times will start staying away so that the caregiver becomes isolated. And even sometimes it's difficult within families because it's hard for families to accept that this is happening. So you'll often find in a family situation that, 1 or 2 children, sons or daughters, will be in denial that there's anything wrong. And some caregivers become embarrassed about what's going on. So sometimes the caregivers themselves instigate the isolation because they begin to keep people away because they don't want to see have someone see their loved one in this condition.
This segues right back into the Reach Out program, because being able to recognize what some of these challenges are for the caregiver, the program then kind of develops what they know is needed to assist that caregiver. One thing that you shared with me, aside from the emotional component that you were just discussing, was also the need to have an assessment of the home for safety reasons.
Absolutely.
Maybe you could share some information on that.
As part of the Reach Out program, on our second visit, we actually do a walk through the home and do a safety assessment, and then share that, of course, with the caregiver, because there's many things. As Alzheimer's disease is a progressive neurological disease, which means over time it gets worse. So in the early stages, things are okay, it's not a problem. But as the person loses more of their brain cells and becomes more impaired, they're not able to make good judgments. their perception is you know, impaired and so forth. So the things are like you can't keep, you have to prohibit access to poisonous items. I had, well, I had a friend many, many years ago. He was Italian and he liked his wine. And one day he thought he would have a glass of wine. He didn't go to find the wine. He went and found the dishwashing liquid, which was the same color. It was white wine, he thought, and he drank it. So it's things that you don't think of like that. Of course, putting away knives and guns, but then as the disease progresses, you have to do things like take away scatter rugs because they're likely to trip over them. If you have a black rug, for instance, in front of a door, they may not want to go through that door because they look at that and think it's a hole. So there's a lot of things that people don't realize are going to happen along the way. So what we can do is either if the individual with dementia is in the middle stages of the disease, we're actually helping the caregiver right now solve these problems that they're encountering. Sometimes we work with people who are in their loved one is in the early stages. So what we do is we prepare them. We talk about what to expect and then to be ready for it.
So you're dealing with not just doing safety assessments of the home, but you're talking about education.
Absolutely.
Go ahead, I'm sorry.
I actually just met with someone recently, and he said to me, well, I've been caring for her for 2 or 3 years, and I actually don't think I need anybody to come talk to me. And so I explained to him that even though he had been caring, that I asked him if he had any information about Alzheimer's and what to expect, and he said no. So he was winging it. And back in 1986, a lot of us were winging it, but it's not necessary for that to happen anymore, because in the last 20, 30 years, we've learned a lot. And so it just makes sense to learn from people who have gone before you as to what works and what doesn't work. And so there's so much we can provide in the way of education based on real life experience.
Well, you know, you make another interesting point, because for the caregiver who has been kind of trudging along day to day in dealing with the patient, because it's a degenerative disease, the behaviors change. So
yes.
Do you also offer support or education along ways for the caregiver to manage those behaviors? Because that must be extremely difficult, particularly if it's a spouse.
Absolutely, absolutely. Number one, it helps for them to understand that it's something as a result of the disease and it's not personal. So that really works well. Then we look, we actually do a risk assessment at the first meeting and ask questions about what kinds of problems they're dealing with, and then with them decide on what priorities they want to work on in the next 6 months. And then if, for instance, if a behavior happens to be that she refuses to take a bath, well, we would problem solve. We would brainstorm around that and make suggestions to them to try. For instance, making sure that the bathroom is warm when they go in, and you know, handing them the cloth, and you know, maybe pre-soaping it and showing them what you want to do. So we work with them, getting some ideas together. Then they agree to try that, and then when I go back in the following month, I will check in and say, did that work? How did it go? And they might say that was wonderful, or they may say that didn't work at all. So then what we do is look at another way, because actually, of course, one thing that works for one person doesn't necessarily work for another. And with Alzheimer's even, something that works one day may not work the next, but may work again the day after that.
Wow. It's very complicated. I can appreciate, you know, how wonderful a resource like this must be for those that are dealing with this on a daily basis. But because we live in a very rural part of the country, and I don't have to explain that to those that are watching it, for many people, they're really living outside of an area where easy access is available. Are you able to use technology in any way to assist in the delivery of these services?
Yes, it's a really unique aspect of this particular grant-driven program. A third of our clients, if they have Wi-Fi capability, we will lend them an iPad. So we will have first, our 2 visits would be in person, but then the final 4 visits would be via FaceTime on the iPad. That allows us to do all the same things we would do if we were in the home, but without the added time and expense of traveling.
Right. I can't imagine how wonderful that must be, just to not worry about a major storm and know that they had an appointment, and if this is of help to them to be able to access you.
Yes.
And just even feeling connected. As you mentioned, the isolation factor is huge.
Right.
So.
It's, and the use of the iPad goes beyond just having the FaceTime with the caregiver support specialist, because they can access, of course, the internet. They have access to things like online support groups. Many families use it to keep in touch with relatives who are out of state, someplace else. The caregiver or even the person with dementia might use the iPad to do games, to perhaps play music. So it has lots of different applications that can be helpful to the caregiver and the person with dementia.
This leads me to another thought, and that being, with especially the experience that you've had in this field, are there other resources or places for the caregiver to go that you feel might be beneficial in helping them to successfully cope with this kind of caregiving?
Absolutely. One of the things we do with a caregiver is